Good afternoon, everybody, and welcome to today's virtual lunch meeting. My name is Sam Chakosky. I'm the Sales and Marketing Manager here at the JCN, and I'm just going to run through a couple of bits of housekeeping before we get started with today's session. So first of all, a big thank you to H&R Healthcare for supporting this session. We really do appreciate it, and I'm sure you'll have lots of questions for those throughout the session, so do make sure you put those in the comments section. Today's session is titled Enhanced Wound Healing with PolyMem Silicone Border, and we have two wonderful speakers for you today. We have Sharon Gardner, and we also have Professor Linda Rafter. Welcome both.
Thank you.
So as I mentioned, we do have live Q&A at the end of the session. So through both of the presentations, please do make sure you put all your comments and questions in the comments section. We'll get as many of those answered in the live Q&A as possible. If we don't get through to your question, we will answer those in the next few days as well. At the end of the session, we will post a link to the certificate for your CPD and revalidation as well. So keep an eye out for that. That will be on the slides at the end, but also posted in the comments section. Finally, please do get involved. You know, all questions will go to Sharon and Linda, but we've got our team behind the scenes as well in the comment section. So if you have any questions for those or any technical issues, we'll be working on those behind the scenes. So without further ado, I will pass you over to Linda, and I will see you at the end for the live Q&A. Thank you very much.
Thanks, Sam. I'm Professor Linda Rafter. I'm a Tissue Viability Nurse Consultant at Wound Limited. I've been a nurse for over 41 years, and I've been in tissue viability for over 30 years. Both in hospital and community. I'm a member of the European Wound Management Association and the European Pressure Ulcer Advisory Panel and the Tissue Viability Society. I have presented at European and national conferences. I have some 56 publications, 5 are in the NICE Guidelines in Pressure Ulcer Prevention and Management 2014, and 4 in the European Pressure Ulcer Advisory Panel 2019. Wound Limited was established in 2010 by myself and my husband. I now hand you over to Sharon.
Thanks, Linda. So I'm Sharon Gardner and I work for H&R Healthcare as a clinical specialist. I also currently still work within the NHS as an AMP at the Walking Centre and also on an honorary contract as a tissue viability nurse. So like Linda, I still work in clinical practice and I still have quite a varied experience within the wound care market. So for today's session, the learning outcome, so what I'd hope for you to achieve at the end of this afternoon's lunch session is to be able to develop an understanding of current wound healing challenges. And like I say, myself and Linda are still clinically seeing patients, so we do understand some of the current challenges that you're facing out there in practice. I want you to be able to recognise what makes PolyMem unique and what makes me get really excited about PolyMem, and it's a genuine excitement that I do have. I also want you to be able to learn how PolyMem can benefit your patients. And if I think back to, you know, traditional lunch meets where I've sat listening to new products, new wound care dressings, you can always think of a patient in your mind that you think actually that'd be really beneficial for that patient. So I really hope at the end of this session, you might have that one patient that pops up in your mind. And I also hope that you'll learn about the dressing range. So there's a really wide range of dressings within the PolyMem range. I'm now going to hand you back to Linda to talk about some of her wound healing challenges that she's faced.
Thank you, Sharon. Clinicians are under increasing pressure to provide high quality patient outcomes at a reduced cost. Increasingly, community staff have to acquire knowledge on advanced wound care products. All of the cases presented here today are complex wounds that require careful management to gain good patient outcomes. Some of the patients in the case studies were in their 90s and were extremely compromised and nutritionally deficient. We used honey and superabsorbent dressings prior to using the PolyMem dressings. I'll now hand you back to Sharon.
Thanks, Linda. So obviously we know we're going to talk about some real life case studies with you this afternoon, but first of all I want to be able to talk to you about what actually is PolyMem. Some of you may have heard of it, some of you may be avid users of it, or it might be very new to some of you. So it's really important that we recognise that PolyMem, it's unique. It's not a foam dressing. It's a unique multifunctional dressing. It's a polymeric membrane. And basically what makes it unique is that it's got individual properties that work on their own, but also those individual properties work together, so they work in synergy to support wound healing and reduce pain. So the PolyMem dressing consists of a mild non-toxic wound cleanser, which is referred to as the surfactant, a soothing moisturizer, glycerol, a superabsorbent starch copolymer, so that superabsorbent property within it to absorb exudate, and a semi-permeable film backing. So how does it work? So I've told you that it's got different properties. How do they actually work? So like I say, it's unique. It's got the mild non-toxic wound cleanser, and it's that built-in cleansing agent that's activated by moisture and released into the wound bed. And it reduces the need for manual cleansing during dressing changes, which we know can interrupt the growth of healthy tissues. The soothing moisturizer, so the glycerol, helps to keep the wound bed moist. It prevents the dressing from sticking to that newly formed granulation tissue, that fragile granulation tissue. And that in turn obviously makes dressing removal virtually pain-free. The starch copolymers, so they effectively wick away up to 10 times their weight in exudate, and that allows the natural growth factors and nutrients to concentrate in the wound bed. Those superabsorbent particles bind the wound exudate, holding it away from the wound bed and the peri-wound skin. So that creates a really nice moist wound healing environment, but minimises the risk of maceration. It gently fills and expands to continually fill the wound bed, so that we know that the actual wound site, the wound bed, is actually receiving the benefits of the PolyMem dressing. And then obviously its backing is a semi-permeable film, which prevents any contaminants from entering the dressing, but still maintaining a healthy MVTR. So how does it actually work? And I really love pictures. I really love things in pictures because I think they really explain things really well. So this you can see in the picture, you've got obviously the wound bed, you've got the superabsorbent polymers, you've got the glycerin in the cleanser, and obviously you can see that the PolyMem is really moulding to fill that wound bed and really filling in that small cavity. So what are the key benefits? So we know what's in it, we know what benefits are they going to provide for your patients. So it's a really, really clever dressing, and this is where I get that genuine excitement about PolyMem. Basically, the dressing has the ability to bring in the body's own cleanup system. So it's got the ability to encourage all those white blood cells directly to the point of injury. And then what they then do is break down the hematoma. So all those red blood cells that formed, the forming that big clot or that big hematoma, the PolyMem breaks that down. So it's pulled everything where it wants it to be, and it allows the body to clear the inflammation faster. So that's what we mean in terms of it modulates the inflammatory response. In modulating the inflammatory response, it alters the signaling cascade and recruits the cytokines to the point of injury. So it's got all its soldiers, it's got all its fighters, it's encouraged them all in, and it's got them all working at the point of injury. It then shunts away sodium ions from the nociceptors. So the nociceptors I'm going to talk to you a little bit more further in the presentation, and that is what decreases the pain signaling cascade. So basically, in simple terms, that's why we've got the lovely picture of the sheep there. It's like herding sheep through the cattle grate. That shunting of the sodium ions is like herding the sheep. So I mentioned to you before that obviously all the components work together, and they do. They work individually and they work together. And by doing that, they provide that thermal insulation to the exposed nerve endings. They gently loosen and lift embedded dirt and debris. We know that they modulate the inflammatory response, so that we know that they're encouraging all those sheep through that gate, and they're controlling the inflammation at the point of injury. And we know that collectively it reduces the nociceptor activity and sensitization, which reduces or eliminates pain. And we know that the modulation of inflammation and pain control go hand in hand together. So I've obviously just talked to you about the nociceptors. So this is a simple, very nice diagram of what a nociceptor looks like. Interestingly, the nociceptor is once that stimulus, which you can see in red, activates the nociceptor, it's actually that point which activates that normal stage of wound healing. So it's a signalling body that sends the signal back up to the brain that there's been tissue damage or injury. And nociceptive pain, it's a rapid onset. So if you think about if you step on a pin, or if you've got young children, if you step on Lego, there is no pain like it. It's that pain that you suddenly feel and you pull your foot away. So it's that rapid onset pain. But actually, nociceptor activity, it's a sustained pain response. It changes, doesn't it? You've pulled your foot away and it's not that same pain, but actually it really hurts because you've stood on a pin or you've stood on some Lego. But it does change in intensity and sensation. It's still painful. And basically that is the nociceptive pathway. So it's communicating along the pathway to the brain that there's some inflammatory changes within the tissue. So thinking about the key benefits continued, we know it modulates the inflammatory response. We know it's absolutely amazing on pain. We know it really, really reduces that pain signaling cascade. I've already talked to you about the fact that it's a wound cleanser. So it continually releases into the wound bed that surfactant, so it's loosening those bonds. So it works in like a cycle. So it continuously releases the glycerol and it creates that moist wounding environment. So PolyMem is a really good dressing to support autolytic debridement. It's a really, really good dressing to prevent the need to have multiple different dressings, you know, something that'll debride, something that'll absorb, because it does all of those, you know, that's what makes it so exciting and unique. So I'm going to hand you back to Linda now because she's got a really, really good case study that she discusses where this has been really effective at debriding a wound.
Thank you, Sharon. This lady was a 63-year-old lady admitted with a hematoma on her right tibia and inner calf. She was known to have angina and fibromyalgia and chronic obstructive pulmonary disease and asthma, which was managed with steroids. This lady was an anaesthetic risk due to a heart failure and lung disease, and so was unfit for theatre. It was discussed with the consultant and it was decided that larval therapy would be appropriate. This lady's wound bed was prepared using PolyMem MAX for 72 hours prior to having larval therapy. After using the larval therapy for 9 weeks, this lady had PolyMem MAX reapplied for 15 days. The cosmetic result was fantastic. This lady had been told, given the size of the hematoma, she would require a skin graft, but as you can see from the bottom photograph, it wasn't required. I'll now hand you back to Sharon.
Thanks, Linda. And I think we'd all agree, looking at that, particularly knowing that that wound was on the leg, those final healed results are absolutely brilliant. I just want to obviously point out that Linda mentioned PolyMem MAX there, so that is something that we'll come on to further in the session. But I just want to say that obviously PolyMem MAX is a dressing within the PolyMem range, and the MAX, because it's got a higher level of the glycerol and surfactant in it, it's really, really more effective at debriding wounds. But we'll come back to them in a minute. So thinking about the indications, obviously it is advised to be used on a multitude of different types of wounds, you know, abrasions, trauma wounds, bruising, because of that modulation of the inflammatory response, because of the dressing's ability to alter the red blood cells in an injury. But I just want to talk to you about surgical wounds. And, you know, surgical wounds might not be the first type of wound in your mind when you're thinking about your patients, where you'd maybe think of using PolyMem dressings on. And the reason I want to talk to you about surgical wounds is because I think PolyMem is absolutely amazing on post-op wounds. And the reasons are, we know standard post-op wounds will absorb the excess drainage from the incision, and we know that they'll protect from external dirt and debris. But PolyMem will do so much more. It'll absorb the excess drainage because it's got that active pull from the incision into the matrix. So it's what we call the capillary pull of the polymeric membrane. And that obviously in turn is going to decrease the tension on the suture line. We know obviously it modulates inflammatory response, and it's that's going to promote and accelerate wound healing, reduce bruising, reduce hematoma and seroma formation. We know that some post-op wounds can be really painful depending on what type of wound or what your patient is. So we already know that PolyMem decreases the nociceptor stimulation, so it reduces pain. And you know, that could in turn help your patient get up quicker, get out of bed quicker, improve their mobility, which we know has greater outcomes for recovery. We know it's going to still protect that barrier that's not going to be occlusive because of the moisture vapor transfer rate. and it optimises the moisture directly over the suture line and the peri-wound tissue and provides that continual cleansing along the suture line. Obviously, I'm not saying it's necessary to use on all post-op wounds, but you know, if you work in an area where you have a high risk of dehiscence or post-op wound infections, so, you know, big abdominal wounds, joint surgeries like knee and hip, where we do see increased amount of inflammation, bruising and swelling, which then obviously do have an impact on mobility, it may be that we consider using PolyMem on those wounds. We obviously know that PolyMem is really, really effective on radiotherapy skin reactions. And I'm going to hand you back to Linda now because she's got a really good case study relating to a patient who had proton beam therapy.
Thank you, Sharon. This was a 74-year-old gentleman who had developed squamous cell carcinoma of his scalp. He was treated with proton beam therapy for 6 weeks. He also had a kidney transplant previously, which made him very immune suppressed. Whilst having the proton beam therapy, he had to have his dressing removed and then reapplied after the proton beam therapy. We devised a PolyMem MAX dressing that allowed all of the areas to be covered that were being treated, as you can see in the first picture. The second picture shows the extent of the wound, and this gentleman found the PolyMem MAX very comfortable, and it did conform to his head quite well and stayed in place with a bandage. I'll now hand you back over to Sharon.
Thanks, Linda. We know, don't we, that obviously some anatomical sites are really difficult to dress, and obviously heads are notoriously difficult. So I think looking at that, a really, really great outcome for that patient. So how do we actually use PolyMem? So I'm going to show you, obviously I've talked about how the dressing is activated in terms of moisture. So if you've got a wound that is leaking exudate, then obviously as soon as the dressing comes in contact with the exudate, the dressing would then be activated. But obviously if you're using it on a wound that is drier, you know, you would want to activate it yourself. So I'm hoping you can see me on camera. I have got a piece of PolyMem. Obviously you can see it's the PolyMem MAX, there's the backing. And all I'm going to do is I'm just going to activate it with some water. So you do this in practice with water or saline. And I'm just going to show you how actually the dressing fills. And obviously then those unique properties become activated. And obviously that dressing's took quite a lot of water. That was 5 mils there. So I'm hoping you can see as the dressing is absorbing, you've got that lovely sort of bubble in the dressing. So you've got that lovely rise there in the dressing. And that's what I talk about when I say that the PolyMem will swell and fill into shallow cavities. Obviously, if we're in person and if like me, you're quite a touchy-feely, you know, you'd really like the feel of that. So you can feel that that's a fact and it's been activated and that glycerol's present and it feels lovely and silky under my finger. So that is how the PolyMem is activated. We also have got a new cutting guide coming out. So we've got a really good cutting guide, dressing application guide. It's not available yet, but if you are wanting a copy, then obviously you can email us at H&R Healthcare and we'll provide you with that email address at the end of the session. So we're now going to show you an application video clip, and this is of the PolyMem adhesive dressing being used. Just want to point out that the new silicone dressing that we're going to talk about doesn't have the bits on the back, the third bit. So we're going to show you the video now.
Thank you, Sharon, for that. I'm now going to discuss a case study of a trauma wound. And and it was a lady who was 73 years old, who is known to have bacterial endocarditis and had a lumpectomy for her breast, followed by 4 weeks of radiotherapy. On the 5th of December 2019, this lady fell at home and sustained a trauma wound to her right tibia, which went right down to the bone. On the 3rd of February 2020, she was commenced on the PolyMem MAX. On the final assessment on the 6th of March 2020, this lady's right lower leg was healed. This lady had a complex wound and made very good progress on the PolyMem MAX from the 3rd of February 2020 to the 6th of March 2020. Using the PolyMem MAX for 32 days accelerated this lady's healing. She also agreed to have a combi compression liner to give her 10 milligrams of mercury pressure to aid a venous return. This combination prevented her from having a skin graft, which her plastic surgeon had advocated and she did not wish to have. I'll now hand you back to Sharon.
Thank you. So basically what we're here to talk about, the new PolyMem Silicone Border. And those of you that have already used the PolyMem range before, I'm hoping that you sat home as excited as I am about this, because it's the same patented polymeric membrane. It's the same formulation. It's the same formulation of foam or polymeric foam, but it's got that secure, gentle adhesive. It's got that lovely soft silicone border, so it's gentle to the skin, it's repositionable, and it's designed to still facilitate healing, relieve pain and reduce inflammation. And it's an ideal choice for patients with fragile, sensitive skin. So with that in mind, I'm going to hand you back to Linda, because she has got some more case studies where she talks about patients that did have very fragile skin.
Thank you, Sharon. So this was a 95-year-old lady known to have a pacemaker, and she was on riboxaban to thin her blood. This lady was very fit and normally swims daily. She sustained a new trauma wound on her left lower leg, which was a skin tear with a star classification of 2B, after she tripped over in the street and banged her leg. The star classification 2B means that the edges cannot be fully appropriated to their normal anatomical position, and that the skin flap is dusky and darkened. After the outcome of using the PolyMem MAX, after 7 days, the purple tissue had resolved, her pain level had reduced, and the actual wound has reduced to 1 centimetre by 0.5. This slide shows the new PolyMem Silicone Border in situ. It's suitable for dry to moderately exuding wounds. It's suitable for very fragile skin, and it's easy to apply. It's very easy to remove without any trauma to the skin. The left lower tibial wound care pathway was changed on the 12th of July 2021 for the new PolyMem Oval Silicone Border. The wound had healed successfully. There was nil exudate. The new dressing was easy to apply, and the dressing changes were performed every 7 days. The trauma wound had completely healed in 5 weeks, and given the complexity of this wound, that was amazing. The next study talks about a pressure ulcer. This was an 88-year-old lady who developed multiple hospital-acquired pressure ulcers in October 2020 of her spine, left heel and left buttock. She was discharged home from hospital with these pressure ulcers. This lady was known to have dementia, acute pulmonary edema and a history of falls and a small pleural effusion. February 2021, we started seeing this lady at home. She was not eating and drinking and had a very poor dietary intake. She was commenced on PolyMem MAX on her spine on the 23rd of July 2021 for 2 weeks. We then changed her over to the PolyMem Silicone Border, and we found that from the 6th of August. This shows, the slide actually shows the wound on the 28th of September, and the pressure ulcer is nearly healed. It stayed in place easy, and it was easy to remove without causing any damage to this lady's fragile skin. And a pain level had to be assessed by her facial expressions due to her having dementia. We'll now go on to the PolyMem finger dressing, and we actually undertook an evaluation of 39 patients using the standard dressing compared to the PolyMem finger dressing, and all of the wound healing was by secondary intention, and they were all trauma injuries to fingers. All of the patients were treated in an A&E department in a general hospital and a minor injuries unit. So the aims of this evaluation were to explore the patient's perception of pain by using the numerical descriptive pain diaries. We explored how the patient's quality of life was affected, looking at the hygiene needs, the dressing needs, their ability to work, drive, domestic chores, and the mobility of their hand function. We also monitored the patient's sleep patterns in line with their injury and pain. We explored the patient's pain at dressing change, and we compared the cost of the procedure time using the two dressings evaluated. We also looked at the use of over-counter analgesia that patients took. And we also explored the nurse's perception of the dressing change. This slide shows one of the patients from the audit, and he was a 24-year-old male who worked as a car salesman. And on the 7th of November 2013, this gentleman trapped his finger in a car door, and that was really sore out. He had surgical debridement in A&E department, and then the PolyMem finger dressing was applied. By the 25th of November 2013, this gentleman's finger had healed, and there was minimal scarring, as you can see from the photograph. The other big thing that was that the pain score reduced from 10 to 0 within 2 weeks of his injury. And I'll hand you back over to Sharon.
Thanks, Linda. And as a person who has trapped their finger in a car door, did nowhere near sustain the injury that chap did, I know how painful it can be for such a long time. So that's great results on his pain scale. So obviously, I mentioned at the beginning that the range of PolyMem dressings is really extensive. So we've got the new PolyMem Silicone Border, which obviously we've talked to you about for a couple of Linda's case studies. We've got the PolyMem Film Island Adhesive, which we saw in the application video. We also have the PolyMem non-adhesive, so that's the polymeric pink foam without any adhesive border. We have the PolyMem MAX and the PolyMem MAX film, which obviously we've talked about being more absorbent and obviously having a greater ability to debride because it's got a higher level of surfactant and glycerin in. We have the shapes, which obviously Linda has referred to in her finger case studies. And we also have the PolyMem silver dressings for infected wounds. So like I say, thinking about the PolyMem MAX, we've got greater absorbency, longer wear time, and that's because the product's actually 60% thicker than the original PolyMem. It's the same specialised dressing with the same multiple properties, but like I say, it's more absorbent. And you can see there in that image, we've got the image of the exudate on the dressing in the shape of the wound, and that is obviously an indication of when the dressing would need changing. Once you can see the full shape of the wound, that the dressing is saturated in the exudate, then you'd need to change it, or at 7 days if you hadn't changed before then. I'm now going to hand you back to Linda, who can summarise some of her findings from the case study she's presented today.
Thank you, Sharon. So in summary, the case studies presented here show how PolyMem MAX can be used to debride a wound bed and relieve pain. The new PolyMem Oval with a silicone border is extremely gentle to the skin and stays in place well, and it can easily be removed from fragile skin. All of the patients have particularly good outcomes, and all of the case studies included were very complex wounds for which it is particularly difficult to gain complete wound healing. And in conclusion, primarily, the clinician needs to work together with their patient to promote cost-effective wound healing. All of the patients in these case studies were involved in their care pathways, and the PolyMem dressings were explained to them on how it would work to promote wound healing. Employing the right combination for wound healing in each individual patient is essential. So ensuring the right dressing is employed at the right time on the right patient can ultimately result in good patient outcomes. I'll now hand you back to Sharon. Thank you.
Thanks, Linda. So obviously we have some additional educational support which we can offer. You know, I briefly touched on how PolyMem works at reducing pain. I briefly touched on how a nociceptor works. But if you go to our educational section on the H&R Healthcare website, there is an absolutely amazing Facebook Live that we've done previously titled Understanding Wound Pain. And that is absolutely amazing. It explains more in depth about the physiology of nociceptors and actually how that inflammatory response works with PolyMem. We also have the e-learning module with Wound Care Today. So there is, you know, additional educational support available to you. We obviously also have clinical support. So we have PolyMem patient and user guides. We have YouTube application videos. We've got the new published paper, which is based around some of the case study that Linda's presented today, which herself and Mark have written around the new PolyMem Silicone Border. I've already told you about the cutting guide, which is coming soon. And obviously we have other PolyMem brochures and the silicone border brochures. So obviously, if you wanted to get in touch with us, you know, if you wanted to evaluate the PolyMem Silicone Border within your trust, you can get in touch with us at marketing@hrhealthcare.co.uk, or obviously get in touch with your local representative for more information. I'd also like to take the opportunity to thank Linda for talking with me today and for presenting some of her case studies. And I'd also like to thank Mark for the work that he's done with Linda around some of the other case studies that haven't been presented today. We really do appreciate it. Thank you. So we're now able to take any questions, and hopefully some really good ones have come through so far during the session.
Yeah, brilliant. Thank you very much, both. That was really interesting, some really interesting case studies there as well. And I do urge all of you to get in touch with H&R and check out their educational support. There's some really good materials there for you as well. So as Sharon said, we have had lots of questions through, so we'll move straight on to the Q&A. Thank you very much, everyone, for getting involved with that, and do keep sending in your questions. If we don't get through all of them, like I said, we will answer them in the next few days. So keep sending them in, and we'll get through as many as possible. So the first question is this one's for you, Sharon. Are there any wounds that PolyMem can't be used on?
So there's no known contraindications or interactions, but obviously with any dressing, you discontinue the use on, you know, anyone who shows any signs of sensitivity or irritation. PolyMem isn't compatible with oxidizing agents, so hydrogen peroxide and hypochlorite solutions. But other than that, you know, there's no known contraindications, and the PolyMem range is latex free as well.
Brilliant, thank you. So question 2 is for you, Linda. How would you dress a wound in the axilla?
Oh, that's not. I think the thing is, you need to make sure that it contours to the wound. And one of the things, particularly if you're using PolyMem MAX, you can contour it to the shape of the axilla quite easily. And just by putting a few cuts, it will then conform to the area it needs to conform to.
Brilliant, thank you very much. Another one for you, Sharon. Is PolyMem effective on painful pressure ulcers?
Yeah, absolutely. And I think PolyMem is really effective on painful pressure ulcers, because if you think about, by the nature of the pressure ulcer, we know that some can be no pain at all, because actually the depth of damage to the nerve endings is so deep. But you can get some really painful pressure ulcers where there isn't that tissue there to cushion, you know, over the bony prominence. So, you know, in light of the fact that PolyMem, it encourages that enhanced healing, you know, alongside sort of pressure relief and pressure relieving strategies, it will absolutely be really effective at, you know, cleansing, you know, a pressure ulcer if there's some necrotic tissue there or debridement needed, and will absolutely provide that pain protection to those areas.
Fantastic, thank you. Question 4 is another one for Linda. Can it be used under compression?
Yeah, we have a patient, we're currently using it under compression and have used it a lot in the past. Yes, it's ideal. And what we have found is that it does relieve the pressure on the pain relief on somebody that has actually got a leg ulcer, and they can be so painful. So it does really work on the nociceptors and reduce the pain, definitely.
Brilliant, thank you. So on to question 5, Sharon. This one's for you. Would this work well with sloughy ischemic wounds?
Yeah, so from a debriding point of view, absolutely. You know, obviously, if you've got a wound that is dry, you know, you've got that necrosis there, you've got that dry slough, and you're not seeing a significant amount of exudate, you could always activate it. And obviously, you can see it's really, really well, whilst I've been talking, that fill from that activation is really swollen. So you could activate the dressing with the saline so that you've then got your active surfactant and glycerol. Or obviously, if you've got a wound that is exuding, or actually you've got quite a significant amount of fluid, you know, exudate within the tissue, fluid swell within the tissue, then it will draw that fluid as well and help to debride that sloughy area.
Thank you. And the next question is on the same vein, but to you, Sharon, again. Does it also contain latex? No,
it's latex free.
Thank you.
Yes,
a nice easy one. We do have lots of questions, so it's always good to get through as many as possible. Question 7, this one's back to you, Linda. Can it be used in open wounds?
Oh, yes, yeah. Again, it's very suitable, and it in an open wound, you're able to just place it over the top. And again, when you redress, you'll find that it's less painful on the second dressing change to what it is on the first one. Yeah. Brilliant,
thank you. And excuse me, question 8 is another one to you, Linda. Is there any trauma on removal? And this person asks because they know some dressings often stick and end up going back to the first stage of wound healing, hemostasis, because of this.
No, it doesn't stick on removal. Again, because you've got the glycerol content in the dressing, then that aids, it stops it from sticking. So again, it's conformable, but also able to lift off without giving any trauma to the wound.
Brilliant, thank you. So question 9 to you, Sharon. How often do you recommend the PolyMem dressing is changed?
So obviously, you know, 7 days, so a max 1 dressing and maximum in place of 7 days. But obviously, going back to that image in the presentation, as soon as you can see that, was on camera, it's the opposite way. As soon as you can see that element of exudate in the shape of the wound, you obviously know that the PolyMem has finished working on that wound, and that's when you'd want to remove it and change it.
Brilliant, thank you. Question 10 to you again, Sharon. Do you advise a barrier on the peri-wound skin, or is that not necessary?
It shouldn't be necessary, really, because obviously PolyMem is so intelligent, because it's got that ability to control the wound environment, you know, because it's got the really nice permeable backing on it. You shouldn't need to protect the peri-wound edges. Obviously, you know, keep an eye and monitor the wound, looking for, you know, skin maceration and things like that, but you shouldn't need to, because it's got that ability to kind of, it ticks all boxes, really. It can absorb the exudate, it can donate the moisture, and it just keeps it really nice balance on that moisture level.
Brilliant, thank you. And now question 11 is for Linda again. Can you use the dressing from stage 1 through to complete wound healing, obviously if there is no signs of infection noted?
Yes, yeah, completely. It is one of the most flexible type dressings, and it meets so many different types of wounds. When it's applied correctly, you've just got a very unique dressing, and it's so much more. We had a an incident the other day, somebody thought they just needed a phone, and it's not just a phone. It does so much more, and it's a particularly good product to have in your toolbox, available for patients.
Brilliant, thank you. Another question for you, Linda. What depth of wound will PolyMem conform to?
Oh, well, with its super absorbency, it can wick into an area very well. But there is also a PolyMem wick, which if it was a deep cavity, you would need to put that in, and then the PolyMem. I would probably use a PolyMem MAX if it's quite a deep wound over the top.
Thank you. Question 13. This one's for you again, Linda. I know that's a few in a row, but is PolyMem a primary dressing, or can it be used as a secondary dressing as well?
Both. It can be used, particularly with the new silicone oval dressing. That's a fantastic dressing to be applied. And again, if it's a second, you can use it as a secondary dressing. If you don't normally need anything under there, but there may be occasions where, again, you would need to use the actual wick as underneath. But 9 out of 10, you can use the new PolyMem oval, and then the PolyMem MAX if it's going to exude a lot more. And sometimes patients want cushioning. I know that we've got a lady on it at the moment on her elbow. She's hurt her elbow, and the cushioning, she talks about the cushioning of the PolyMem MAX, which again, obviously the reassuring, particularly for elderly patients, if they have got, they've injured the leg or their arm, then it just gives them that additional protection.
Brilliant, thank you very much. Back over to you, Sharon, for question 14. Is there a silicone contact layer all over the surface on the dressing?
No. So where the dressing is, so you've got your silicone border around the outside of the silicone dressing, it isn't covering the whole of the PolyMem, because obviously we want that foam to be in contact with the wound bed. Going back to that, you know, it is a primary dressing. We want that to be in contact with the wound bed for it to be able to be effective. And obviously it's not necessary to have the silicone over the dressing, because we know by its mode of action it doesn't adhere to wound bed, so it doesn't need it. It's just got it on the border where it's going to be attached to the fragile skin.
Brilliant, thank you very much. So on to the next question. This one's back to you, Linda. Would PolyMem work in inflammation but with intact skin?
Yes.
Excuse me.
Yeah, I mean, we've actually seen it where it's been used on a bruised area, and then when you remove it, and particularly the skin tear lady, that all that purpleness that went was amazing. But you can use it on a bruised area, and it will reduce the bruising. Maybe deep tissue injuries for pressure ulcers. Again, if that takes the deep tissue injury away, then obviously that's very helpful for a lot of the tissue viability nurses out there doing clinical work, because it will reduce their number of incidents.
Yeah.
Brilliant, thank you. And this brings us on to our last question. And the last question is for you, Sharon. Does it have antimicrobial properties?
Yeah, so obviously in the range, and I'm glad Linda mentioned about the wick. So we have the wick version, which I have actually got some here. So it's basically just not got the polyurethane backing on it. That's what we use in cavities. And obviously you can see where I was putting the moisture on there, that's swollen in size. So we do that in terms of packing, but yeah, absolutely. We have the silver version as well for, you know, like we've talked about, if a wound's infected, can we use it on intact skin? So if there is an infected wound, then obviously you'd use the PolyMem silver range.
Brilliant. Well, thank you very much for answering all those questions. I know there was lots of them to get through. I'm sure there's plenty more that we'll get through in the next couple of days. But thank you so much for all your insights and for your presentations. Really interesting. I know we've had lots of comments through already. So do have a look at those when you're recovered from doing this presentation. Thank you everyone in the audience for watching. We do really appreciate you giving up your lunch hour and joining us today. leave any comments. Make sure you ask any more questions that you have, and we'll get through to those as well. Finally, thank you very much to H&R. Do make sure you get in touch with them if you'd like to evaluate PolyMem Silicone Border. Then you can email marketing@hrhealthcare.co.uk, or you can get in touch with your local representative. And then from us, our certificate link should now be on the screen and should also be in the comments section, so you can download your CPD certificate for revalidation. The video and the slides will also go onto the JCM website, so have a look there if you've missed anything or want to watch back. And finally, next week we're on the road in Milton Keynes for our National Wound Care Today conference. So I think both Sharon and Linda are going to be there. I'll be there as well. We'd love for as many of you guys to come and join us as well and say hello. So have a look on woundcare-today.com. Register for your place. It's free to attend. We'd love to see as many of you there as possible. So that's all from me. Thank you again, Sharon and Linda. Brilliant session. Thank you all for joining us. Enjoy the rest of your afternoons, and we'll see you next time. Thank you.